and the session will short.
So is Aarti is sorted out?
Sir, you are sorting it out. It's just a technical issue.
Achha, okay.
We are live on YouTube now. Over to you, Dr. Kaushik.
Yes. Thank you. Welcome all of you to our this medico-legal aspects webinar by Young Ophthalmology Society of India. This is our legal team. We also have a legal advisor with us. We have already covered topics including consent, Consumer Protection Act, record keeping, indemnity insurance, how to respond to a legal notice, medico-legal issues regarding TAS and endophthalmitis, telemedicine and its medico-legal aspect, cataract surgery and related to medico-legal aspect, ROP and its medico-legal aspect, and how to issue a medical certificate. Now, this is our current webinar focuses on the uses of intravitreal anti-VEGF agents and their medico-legal aspects. We are privileged to have Dr. Ananti Deshpande sir, who has been our guiding force since the beginning. Sir is the director and eye surgeon at Guru Prasad Netra Rugnalaya at Aurangabad. Sir is director at Indian Medicolegal Consulting Services Private Limited, where he has helped already many ophthalmologists in their time of need. He is chairman, legal committee,
co-chairman, sir.
Co-chairman, yes.
Yeah.
And he is faculty of law and visiting professor of Symbiosis Law College, Pune. He has written various books in like legal aspects in ophthalmology to an MFU. He has also played crucial role in preparing the consent book from AIOS. We are privileged to have Manoj Mathur sir. Sir is advisor and past president of Telangana Ophthalmology Society and Hyderabad Ophthalmology Association. He has served as managing committee member of AIOS. He is a consultant ophthalmologist at Swarup Eye Center, Hyderabad. He is also currently the treasurer of AIOS. We also have Prakash Marathi sir, who has been helping us since the beginning. Sir is past president of Maharashtra Ophthalmology Society, Pune Ophthalmology Society, and Indian Medical Association, Pune. And Sir has been past senior vice president of IMA Maharashtra State. Sir has multiple awards to his credit. And our speaker is none other than Dr. Ajay Aurora sir, who had played a vital role in during the Avastin saga when our Drug Control Authority of India actually banned intraocular use of Avastin. Sir is a director and senior vitreoretinal specialist at Vision Plus Eye Center and MMR Eye Institute, New Delhi. Sir has done MBBS from Jawaharlal Institute of Postgraduate Medical Education and Research, Pondicherry, and Sir has done fellowship in Retina from Retina Foundation, Ahmedabad, in 1997. Sir has received multiple awards, which include Santosh Wati Memorial Award, Jeepmar Merit Scholarship, A.C. Agarwal Trophy of Delhi Ophthalmology Society. And Sir has been playing very guiding role in VRSIs, specifically in things related to endophthalmitis in anti-VEGF agents. Over to you, sir. Thank you.
So can I start?
Yes, sir, please, sir.
Is it visible?
Yes.
Yeah.
So at the outset, thank you, Kaushik, and thanks to YOSI, thanks Aarti, and it's my pleasure that we have Dr. Deshpande, Dr. Manoj Mathur, Dr. Marathe with us. So I'm today talking on, as requested by Kaushik, on story of the Avastin saga and the medical legal aspects of the use of anti-VEGF agents in ophthalmology. While preparing for this topic, I realized how little I knew about the legality of all these aspects, and it's very important for all of us to educate ourselves. And that's a big lacuna in our training throughout as students and subsequently as clinicians. So let me just not moving. So anti-VEGF, this all started way back in 1989, and this man, Dr. Napoleon Ferrari, and his colleagues at the Genentech were the first to isolate and clone vascular endothelial growth factor. Now, this led to the introduction of Avastin, then Lucentis, Eylea, and then we have other agents which are which is like now the brolucizumab or faricimab, which is going to come up soon next year in India. Then we have numerous biosimilars like ranibizumab, various biosimilars of ranibizumab, bevacizumab. The aflibercept biosimilars are yet to come, but are on the way, and we have ziv aflibercept. Now, the credit for Avastin goes to Dr. Phil Rosenfeld, who is a professor at Bascom Palmer. And it was in 2005, in May 2005, when the entire Avastin story started. It was a nurse at Bascom Palmer who had lost one eye following PDT in her eye. And in the other eye, she had received Kenalog and PDT, which was not working adequately. So here, Dr. Rosenfeld had a molecule which was being used for the colorectal cancer. And he said, let's use it because it had the right properties. Appropriate consent was taken, and rest is all history. So what I'll be talking today will be the Avastin saga. We'll be talking on the informed consent, off-label use, medical-legal cases at the tips, and a little bit of the discussion. So there is none so blind as one who will not see. So, vision is not purely vision, but is to look beyond what we are seeing, and that is what is important. It was on 21st January 2016 when lightning struck our country and when Avastin got banned. And that was a Thursday, I remember. And on 14th January, this was from the constituency of our Prime Minister, when in Ahmedabad, 15 patients lost their eyesight because of endophthalmitis following Avastin injection. And 21st January, DCGI decided to ban Avastin pan-India. It was a little later after the ban had been done that Avastin was again used in Varanasi, and 5 patients got infected. And this became a major hue and cry in the media because they had found something to talk about. And, they always try to bring the doctors down. And that's what happened at that stage. Now, what were the consequences of banning Avastin? We realized that every day we calculated about more than 3,000 injections of Avastin were being given in the country. There were 1,058 known centers where intravitreal injections were being given, and there were many ophthalmologists who were giving it, and many we may not be aware of. So there's a large volume of doctors would suffer if Avastin was banned. So it was at that time, I remember within 2 days, Dr. Devashish Bhattacharya, who was the president of AIOS at that time, called in the meeting of the AIOS and BRSI. I met with Dr. Lalit Verma. We went to the ministry and had the initial meetings. Multiple meetings were held with the Ministry of Health. And Dr. Devashish, Dr. Rammurthy, Dr. R.V. Azad, Dr. Lalit and myself, we met the Secretary of Health. We later on decided that we'll take on, because it had this was never a ban had ever been reversed in the history of DCGI, but we decided that the stakes were very high and we'll go all out to do whatever we could. So this 15-member expert committee was formed under the chairmanship of Chief of RP Center, Professor Atul Kumar, and we had representatives both from AOS and VLSI. With the help of a lot of people and guided by Dr. Atul, by Dr. Lalit, we went ahead and prepared a 244-page document. And this was because of the support which we got from all over the country. We had formed a WhatsApp group, and a lot of people gave suggestions. They were all incorporated. We connected with a lot of our friends and people who are higher up in the US, connected with the American Society of Retina Surgeons. And we got a lot of documents from them, which I'll be showing you and sharing with you. And we ended up preparing a 244-page document, which happened over the period of a few days. And this we went and showed to the then Health Minister, Dr. J.P. Nadda. And it was absolute sheer brilliance on his part. He leafed through the document and wrote just one line on it. And he said, which will blind people more, the availability of Avastin or the non-availability of drug, which already meant that he had conveyed his feelings for the people under him to take appropriate action. We shared a lot of data with the team, and on 8th of February, a meeting was called by the DCGI, and this meeting lasted more than 6 hours, which was attended by Dr. Somani, by other officials of the DCGI, representatives from AOS, VLSI, and representatives of Roche. So there were some presentations made, including the presentations by Roche, and I'll share a little bit of what we told them. We told them that, look, Avastin may be a drug which has not been approved for intravitreal injections, and so is triamcinolone, so is TPA, so are various antibiotics which are being given. And these drugs are not manufactured for intravitreal use. Then why condemn Avastin? So we also shared with them the FDA data, that how FDA had relented to the off-label use of Avastin. We also said that ringalactate was being commonly used all over India for cataract surgery, and ringalactate is not permitted for intraocular use. Then why not ban? We asked DCGI, why didn't you ban ringalactate as well? So based upon all these and the data, we showed them the PATS data, which said that the commonest anti-VEGF being used in the US at that point of time was Avastin. We shared the CAT data with them, the IVAN trial data, and we showed that the cost effectiveness of Avastin was certainly much, much superior to the use of other agents, and therefore it was not possible to ban this agent. At that time, we had data from Shankar Nethralaya, where Dr. Rajiv Raman had shared this data, and it showed us that the incidence of endophthalmitis after use of Avastin was extremely very low. I connected with the chairperson of the American Society of Retina Surgeons, Dr. Jeffrey Emerson, and he was kind enough to write a personalized letter, and I'm just sharing the letter with you, which he wrote to the Department of Health, Government of India, and he showed that the endophthalmitis rate with bevacizumab, that is Avastin, was 0.017%, and it was higher with ranibizumab, basically showing that Avastin was certainly not the culprit. And the paper had come out by Dr. Rosenfeld, which we again shared, that Avastin doesn't blind people, it is people who blind people. Now, WHO also had recently incorporated Avastin into their essential drug list, and they had not included ranibizumab, though it was considered, but Avastin was chosen. So basically, this set the ground for the reversal of the ban, which actually happened. And during that meeting, we promised DCGI that we'll come out with the Indian guidelines of intravitreal injections of anti-VEGFs, particularly Avastin. We will go through the procurement protocols, the storage protocols, the injection techniques, the follow-up that is required in these cases, and these are our responsibilities. So it was also shown that the problems with the drugs was the counterfeit medicine and the lapse in cold chain, multiple use of multi-dose vial, and certain techniques which are not aseptically followed, and some injection-related techniques. Now, we requested Roche that Roche should provide us an authorized list of distributors so that the medicine is procured, Avastin is procured from the distributors, rather than going ahead and buying any discounted drug or a cheap medication. It was important that the cold chain should be verified and that the drug should be examined physically, and the Kessler code, which was available up to 2013 with Roche, should be reintroduced with Avastin. So this is just an example of the Avastin vial, and this was shown to in the group meeting. And we show, please note here that there was a warning on the vial which shows to be sold by retail on the prescription of the oncologist. I compared the vial data which was presented in Australia and Europe, and that does not have this warning. So it was particularly for Indian market that there was a warning given, and it was said that it will be bought only by the oncologist, which was definitely not correct. And these are just to show you the vials which was available. We showed the Roche people that if you open the vial from below, it can easily be opened, the bottle removed, and a spurious vial introduced inside. But if you open it from top, there was this seal will break. And when the seal breaks, you can identify that it is a vial that has been opened. So why would anybody who knows this fact will open it from the top? They will open it from the bottom and replace the vial. And we showed it to Roche that this was a blunder they had made. And this is just to show you that about the
Imagine a
Kessler
world where
code.
each of
And
your
I'll just
products
stop
is
speaking.
as unique as you
Just
are,
listen to the video.
where each can tell its own story. Kessler connects you with your products and consumers to unleash new business possibilities. Are you looking for an innovative way to grow sales, boost brand equity, and create a deeper understanding of your consumers? Then your products should be Kesslerized. In a world filled with marketing noise, Kessler codes can help you have a meaningful conversation with your consumers. When a consumer interacts with the unique identity of your product, they tell you a bit about themselves, their buying behavior, and the exact product that they've consumed. With fresh insights into your consumers' behaviors and new relationships that are independent of retailers, you'll be able to create exciting promotions that have an impact. So while your consumers are being rewarded for their purchase, you'll be rewarded with new sales growth. Kessler helps you unlock your potential within brand activation. How do your consumers know that the product they are buying is genuine? Now your product can answer that question. Consumers are empowered to verify the authenticity of a product in seconds. Our easy-to-use solution ensures that product verifications can be delivered across a large range of devices and channels. Kessler's service reduces risks for brands and protects consumers and patients from using counterfeit and possibly dangerous products. 7 of the world's largest pharmaceutical companies have partnered with Kessler to provide their patients with the confidence that the products they are buying are genuine. With increasingly complex global supply chains, Kessler delivers real-time product visibility in your supply chain. At any time, you can have an overview of your product, track where it's been, who it's with, and where it's going. Our solution is designed without limitations of traditional track and trace systems. What you gain is higher performance, security, and scalability in a significantly smaller IT footprint. This results in lower total cost of ownership. With Kessler's patented technology, you'll be up and running in no time. To learn more about our innovative approaches to growing.
Basically, this is a 16-digit alphanumeric code, and up to 2013, all the Western vials we were using it routinely. We will just punch in the code, and we will get a verification that the vial is authentic. And for some reason, Roche decided to discontinue it beyond 2013. Then I went ahead and asked the Kessler company, which has got its head office located, the India head office located in Mumbai, and the cost of incorporating a Kessler code was only 7 rupees. So we told Roche company that doesn't matter, we'll pay extra, but you include it in Avastin. And then we showed them what Pfizer had to say about Kessler, and Roche also showed that their own director logistics had said that patients who were buying their products can SMS the code printed on the pack, which the Roche would confirm it to be a genuine product. And Roche had experienced till 2013 that their products, the safety, the genuineness was being verified. So this was important, and we wanted Roche to introduce the Kessler code, but unfortunately, after 2013, it has not been done, which we are still awaiting. If that was there, we can always identify a spurious vial. Now, what we require is that the cold chain should be monitored. The Avastin should be procured from the distributor. The end user should be able to check the authenticity of the drug, which can be examined by a physical examination or by the Kessler code. And we should not take Avastin on cash, always taken on a bill. And after that, it is a responsibility of the end user. You must keep it in a fridge at a temperature between 2 to 8 degrees centigrade. And that fridge should be connected with the UPS, so electricity should never go away. There are 2 ways of injecting. Either you aliquot, or you can have directly from the vial. And for that, we had prepared a consent and the methodology of preparation and the methodology of using direct from the vial. Invariably, you should use it within 15 days. When you first use the vial, the sample should be sent for the culture. And after that, in case it is being used beyond 14 days, a second sample should be sent after that. Most people were using it by pooling of patients. At that time, biosimilars were not available, and this is how it looked like. Arvind Eye Hospital and RP Center were making glass vials, and that is the ideal situation. And we looked at the data provided by the FDA, and we showed that what criteria is the best utility before which the drug should be used. And we requested the DCG and the expert committee for revoking the ban. So this is the end of the presentation. Influence Roche to bring the Kessler code, remove the caution on the Avastin drug, which says that it should not be cannot be bought by an ophthalmologist, allow off-label use if possible, and on-label use, which of course will not be done, and make the authorized distributor list available on the website. And we decided to agree and to work with the DCGI. So this was then on 11th March 2016, when we received the notice from DCGI that the ban had been revoked. So this was a historic achievement, which was first time it happened in the history of DCGI, and first time an off-label drug, DCGI had allowed its use in the country. Having achieved the reversal, we went ahead and prepared the AOS and VRS prepared the consent form and consent forms from other VEGFs which are being used even today. So those guidelines have been circulated, and it is available on the AOS website, and you can download the form from there. It is also available on the VRSA website, and you can download from there. So from the consent form, there are certain important things which need to be talked to the patient. We must discuss the alternatives to Avastin. We must show them that Avastin is safe and it has been used in larger trials, though it is off-label. The complications are related to intravitreal injections are common, and we must discuss patients' responsibilities that in case they have symptoms suggestive of endophthalmitis, they should immediately come back and show. So we know that FDA, the Avastin is not FDA approved, but FDA has allowed its off-label use, and patients should know that. And though we normally take a consent every time we inject, but it is believed that if you take a consent once and the patient is getting repeated injection, the consent is valid till it is revoked. And I'll request Dr. Deshpande sir later on to opine if a consent has to be taken every time. It should be signed by the patient and the witness and the treating doctor. Now, before I go, so now I'll try to show you some cases which I have tried to look up from various cases that have come. So I'll just share some of what I have learned in the process of going through these cases. Now, nobility of the profession is dead or dying, and we are not living in a utopian world, and we must realize that. Even patients who receive treatment free of cost in India are considered as consumers. Now, it is believed that the art of healing, where the doctor was placed next to God, actually has become a service, and therefore we are covered under the Consumers Code. While judiciary and lawmakers are protected, so they can lose a case and they can go wrong, and this is all done in good faith. But the doctors, if they go wrong, even if they have done it in good faith, in camps or free eye camps, they have to pay compensations. So doctors must understand the law and guide their lawyers. So recently, a patient following LASIK surgery of high myopia who underwent toric implantable Collamer lens for unsatisfactory result claimed a sum of 60 million plus for compensation. So this was the hospital hired an investigator and tried to follow up that patient, and they found that the patient was doing well, was gainfully employed, and active on social media. So therefore, it is important as doctors that we have to also help our lawyers understand what is going on and find out solutions so that the case can be explained properly. I'll go over a few cases. This was the famous case which was with Joseph Eye Hospital, one of his branches where endophthalmitis occurred. So this was a case which showed that despite Pseudomonas having been cultured from the ringer lactate, the manufacturing company was absolved. The hospital had to pay up, but the ringer lactate which was procured from the company, that company showed some other stocks which were tested negative for the organism, and hence they were not considered as involved. This was the case of A.S. Mittal versus UP State, and you may remember that many years back, Dr. R.M. Sai, who was a leading ophthalmologist in Jaipur, he had done a camp. At that time, I was doing my post-graduation, where there was a camp was done in Khurja, and then from there they had gone to Moradabad. 84 persons in Khurja and 15 persons in Moradabad lost their vision. Now, a lot of people were involved. The Rotary was involved. UP government was involved, and the government paid all these people 5 lakh rupees per person, plus money was sourced from other places. But during all this time, the professional associations prefer to maintain a golden silence. It is important that AOS does advocacy and state societies must help. AOS does not have a protocol that if events like this happen, how should AOS respond? We keep discussing and we do provide lip service, But I do not think that we go ahead and help an individual, because we have realized that an individual, it is very difficult for an individual to defend themselves. It is very important for All India Ophthalmic Society to support them. Now, in 1995, the Supreme Court delivered a historic decision on the Indian Medical Association, which showed that the medical profession should be considered as a service and hence comes under the ambit of Consumer Protection Act. So the relationship between the patient and a medical professional from that year has become contractual, and hence the Consumer Protection Act is applicable here. So this was a very drastic change that happened in 1995. Now, this is a case regarding use of an Avastin of a person by name Mr. Vinod Sanghi, and Dr. Manoj Mathur may know. This is from Hyderabad, Telangana. This is regarding New Retina Eye Center. Now, I went through the entire case and found that actually the doctors had done exactly what should be done. Now, patient had complained of blurred vision in the left eye. He approached Neo Hospital. He was advised injection Lucentis versus Avastin. Patient chose Avastin because it was costing less. The injection was performed on 20th February 2014. 8 other patients received the injection the same day. One of them complained of pain and blurry vision, and the patient was called back the same day. Mr. Sanghi chose to come the next day, underwent pars plana vitrectomy and intraocular antibiotic injection. And what they found, that the patient grew Pseudomonas and Klebsiella. Now, this was because the injection was possibly a spurious drug which had Pseudomonas and Klebsiella. So the patient, everything possible was done for the patient surgically, very close follow-up. A second surgery was done, and the new hospital also filed an FIR, also communicated to the right authorities. And I will not go through the case. Actually, I thought I would, but may not have time. So I'll go to the last paragraph, which says, the opposite parties, number 1 and 2, which means the implicated, the new hospital, have admitted that various treatments, including vitrectomy surgeries, intravitreal moxifloxacin, posterior subtenon triamcinolone, multiple consultations, etc., were done free of charge. So they found that the total cost of managing the adverse cost, even for the patient, was about 2 lakhs. Therefore, it can be said that the opposite parties, number 1 and 2, have committed negligence of administering an off-label drug. So they did not find any problems with the protocol, but they found problems with the use of an off-label drug. And hence it is very important for us that, now that biosimilars are available, many people would prefer not to use Avastin, though if we have explained that it is an off-label drug and have documented in the consent and taken patients' acceptance, I think I still continue using Avastin. I would like Dr. Deshpande sir to give his opinion. Now, this was the ruling by the court, which said, I would not go through it, but basically saying that that essentially, basically, because it is an off-label drug, therefore it is necessary for opposite party number 1 and 2, that means the new hospital, to pay to the patient who suffered, and he was paid 5 lakhs rupees. And just imagine that the Roche company, which had been summoned, the complaint against the opposite party number 3, that was Roche, was dismissed without any cause. Now, learning from this case is that individual doctors find it extremely difficult to pursue legal route. It is important for the All India Ophthalmic Society and State Society not to remain mute observer in these cases. They should take up the cudgels and support the use of Avastin Or in case Avastin is not to be used in a country, we should come out with a white paper against the use of Avastin so that everybody is clear about it. There's no white paper which says whether it can be used or not be used, because once DCG has revoked the ban, Avastin can be used, unless and until AOS bars all ophthalmologists for not using them. We need to have the Kessler code, and therefore AOS must pursue with Roche to come back with the Kessler code, and we must do advocacy through media as well as politically. We should consider using biosimilar or Avastin. I think that's a very personal choice. But yes, that is an option now available to us, which was not available in 2016. We must, however, only use approved biosimilars of ranibizumab. We have biosimilars of Avastin available, and I personally think it is wrong to use biosimilar of a drug which itself is off-label. We must, when we start using any molecule, should get a copy of an FDA approval or DCJ approval of the anti-VEGF molecule, by either say innovator molecule or it is a biosimilar, and have it on record with us so that in case it is necessary, it can be shown to the patient or to the lawyers in case it is ever necessary. We must use the consent that has been published by the VRSI and AOS, and large number of ophthalmologists have now started using Paginex. Now, many times they do not inform the patient that Paginex can cause intraocular inflammation and what are the alternatives available. I think this is because a lot of multinational companies pressure, and we must tell our patients of what they expect. Now, there is another case which I thought I'll just touch upon, just to show you that how good documentation helps and how support from our colleagues is helpful. Please remember that most of the cases of litigations is because one of our colleagues has spoken ill against us or against whatever has been done. So here was a patient who was treated in Dehradun, Mr. Ravi Pradhan. He received Avastin injection, developed endophthalmitis. Next day, underwent pars-plana vitrectomy, was given the right treatment, and on his own, he was the doctor there. We know her personally. In fact, you can find out. Referred the patient to go to AIMS or PGI. Patient refused, but he did go to one of our colleagues in Delhi. The patient, he was told that the treatment that has been given to the patient was appropriate. The patient also went to another colleague in Amritsar, and again the same thing was told. And the patient came back and followed up with the doctor in Dehradun. So the court said that if you have followed up with the doctor, despite getting opinions from multiple places, there is no negligence of the doctor involved, and hence the case was dismissed. So just going to show that a positive word from our colleagues and good documentation helps a lot. Now, before I close, and I think this has been covered earlier, it's important that all of us must have good indemnity insurance. It has now been shown that we must have an insurance of at least 50 lakhs. We must list out all the places of work, including an ICAM. In case you're doing work in an ICAM charity work, you must list it out. It should be there on your insurance. You must include the support staff because they can do some omissions and commissions. And the cost of including them into your insurance policy is hardly anything. It is 7.5% of the basic premium. You must make sure that the policy is retroactive, and the policy should cover a single event as well as multiple events. And it is usually a good idea to get a policy through a consortium of organization, which may be in your place, wherever you are, or an Indian Medical Association consortium, and that works very well. And I said earlier, documentation, we must document everything very well. We must avoid abbreviations. it is preferable now that EMR is available to print out all prescriptions, write the dosages and the duration of treatment correctly. The consent must be, and I believe now the printed consent, as has been shown in 2020, there was a major judgment in 2020 which said you should not use a printed consent form. Every consent form should be customized to that patient. That means if there is a particular indication of why there is a risk in that patient, that must be handwritten there, and the patient must be explained in their language which they understand. We have so many meetings which are conducted, which are supported by the multinationals because they have equipment to sell or they have drugs to sell. But there are hardly any meetings like this one, which is supported by any of the multinationals. These are the meetings, I think, which are very important. And I think the state societies and the AOS must educate doctors like what YOSI is doing. And I must really, it's very nice that you are doing this. This is very educative to the doctors, because that is the only way we can ensure that the doctors stay out of jail or stay out of courts. That's a little harsh thing to say, but I think it's very important. We must stand with the doctors in the time of need and provide them actual support rather than lip service. Thank you very much.
Thank you, Dr. Aurora. I have to say that Dr. Aurora has nicely narrated everything about Avastin on both sides. But the thing, what he has given me 5 points on which I have to give. And first point is Avastin and endophthalmitis. There is a written that it is not for ophthalmic use, off-label drug. Secondly, there is no preservative in that. So first prick is always safe, but second prick to the vial is not safe, because even a small amount of organisms introduced in the vial can proliferate and can cause the endophthalmitis. And this was the attitude of the judge in a case which I have met with. I don't want to give in detail the name of the hospital or the persons involved, but the case was that in a hospital, government hospital, the Avastin was given. One day, there was a day fixed for giving the Avastins. All patients were called, and the Avastin were given for 10-15 patients from a one vial. So first vial patient was good, second was good, and last 5 got infected and patient gone in the court. The court said that I will call the company. And they called the company people, R&D people, and they said there is no preservative. So a single bacteria gone with the first prick can cause endophthalmitis to the second person. So this was the attitude. So we have not labeled it, we have labeled it offline, and it is not for the use in the vitreous, because vitreous is a good a media for proliferation of the organisms. And the thing that when the pleading was that post-operatively, if infection happens, so it is the thing which is mentioned in the book. So it is not a negligence, and doctor can be safely taken out of it. And as it was done in Indore, AIOS has taken pains to see that Indore episodes doctors should not be suffered. And I was the person who visited the Indore 4 or 5 times and inquired all the matters. And first of all, I put the hold the matter in the High Court, and High Court immediately accepted that there is no negligence of the doctors. So doctors were totally out. The hospital High Court also said that a hospital should not be closed because other people are getting suffered. So what was their fault was in the sterilization. So here doctor knows that second prick is going to cause infection or may cause the infection. That is the negligence of the doctor, and doctors were not saved in that case. So that is the position, because if their doctor knows that there is no a thing that preservative, and so why you are using, about the cost. If you think of the cost, there are so many operations which are costing more than that, and people are affording. And nothing is more than a eye. No cost is more for a eye, because becoming blind is the biggest thing. And so instead of using Avastin, if other drugs are available, maybe those come a little more costly, the funds should be made available from any other fundraising people or other organizations or through the insurance. But one should not give the in a drug which is off-label, and the doctor is knowing that this may cause the endophthalmitis and can cause the blindness. Another thing is that of the taking of the consent. The thing is that even if the patient says, kill me on the case table, doctor, if kills him because he has given the consent, he is now no more saved, because consent doesn't protect the doctor for doing illegal things. And the court says that this is an illegal thing where it is off-label drug, there is no preservative. When you know that it is going to cause the endophthalmitis, why you are using it for the sake of only cost? And so the case was against the doctors. So when in this condition, I will only suggest that when you are not giving Avastin, instead of giving the Avastin, you should ask the patient to have insurance, and through the insurance pay the remaining cost or whatever it may be. But one should not do it, and if he does it, he has to face sometimes the legality. Nobody can save him. Even the records will not save, because the record will show that you have done the negligence.
Thank you.
All these 5 points are, I think, covered, which he raised about. Dr. Aurora said very nicely raised. He very nicely raised. And as far as possible, I tried to myself explain the points.
Thank you, Dr. Deshpande sir. I think it was very nice presentation by Dr. Ajay Aurora.
Yeah.
Being the vitreoretinal surgeon, I think the topics what he discussed was along with medico-legal aspects of that intravitreal injection, and that was a fantastic presentation. I definitely appreciate it.
Yeah,
and
definitely.
The comments by Dr. Deshpande sir were also perfect, because he's the real medico-legal expert. Two points from my side. As Dr. Ajay Aurora said, when the patient comes repeatedly for injections, the consent should be taken every time, or only one consent will suffice the purpose. I think, according to me, taking consent is not that problematic. You can have consent in each visit of the patient. Whenever the injection is given, you can take consent every time, because whenever there is a surgery like cataract, both eyes, you are taking consent for each eye. Whenever there is a procedure, you are taking consent. So it is better to take consent every time. That's what I feel. Expert
must
opinion
be. I will say, not better, must be.
Taking consent, I think that is the better option, because what Dr. Ajay asked, whether it is to be taken only once or multiple times. So my says it can be taken, it must be taken multiple times. Another thing is, it is my question to all the panelists and the speaker here. Like, it is the bulb and multiple injections are taken from that vial. Now there is chance of infection. So why don't we think that it should be single-use vial? Like,
that was also suggested by the court. Why the company was bringing the single vial, and company said it is not profitable, so we are not going to do it.
That's what I'm saying. Suppose it is profitable to company in their aspect of financial aspects, they can increase the cost of that ampoule or that single dose vial. And suppose that patient is in a position to purchase that, and if the hospital is also ready to use that vial, I think that is the better option as compared to the Indian drug and imported drug, which is very costly. So in between, that can be the option available for each and everyone. So I think we at the AIS platform and VRSI platform, we must promote that, and we must suggest to pharma companies to come out with single dose vial. That's what I feel.
So can I, Dr. Manoj, please go ahead.
Yeah, like even I was feeling the same, like since we have the voluminous data as of now in India as well as in foreign countries, two things can be worked out. Number one, why not label it for ophthalmology use also, intravitreal. We should move in that direction. Second thing is the single dose thing. Like if it is not profitable to the company, that should not hold. Like the court can issue a directive that they have to purchase. Like suppose if it is costing 25,000 for 5 injections, the company can charge 10,000 for a single injection. That is better option than purchasing a 25,000 vial and using it only for one patient. And the court is also justified after the hearing the wonderful exposition from Ajay about the thing, like the culpability lies with the hospital and the doctor. Suppose if it is a multi-vial injection, the company is not responsible for the infection. The company has supplied a sterile form. The infection is happening at the administration level. So the doctor has to be held culpable. The courts will not save the doctor on that count, I feel.
So can
I think the way forward is to either use a biosimilar or insist for a single dose vial, or like, we, as Ajay has demonstrated, even with the proper consents being taken, with the risk being explained to the patient, still the risk of infection, the doctor is held culpable.
I think at society level, we should try this, that on that particular single-use ampule, it must be written as ophthalmic use only.
Yeah,
Yeah,
that is
absolutely.
true. And with the preservative, it should come and should be written that for ophthalmic use. Maybe rise in price.
Yeah.
So can I bring in a few points here, sir?
Yeah.
One is that if you look at the availability of anti-VEGFs available in the US, the commonest agent be given today is Eylea, and the next to that is still Avastin. The next to that is still Avastin, and it is not ranibizumab. It is not Lucentis. Now, why is that happening? It is happening because Avastin is being used by the compounding pharmacies, and as Dr. Deshpande said, it is taken once in a clean room. In a clean room, it is taken once from the bottle and aliquoted into 10, 12, or 15 syringes, which are separately labeled and used individually. And these syringes must be used within a period of time, which is known as BUD, best before time, which is defined by the American Society of Retina Surgeons as 14 days. It was earlier 9 days. Now it is 14 days. So this 14 days is from the point of time when these syringes were created till the point of last day when they can be administered, which means the syringes have to travel from the compounding pharmacy to the doctor's the hospital, and you should have adequate patients available and use it within that time. Now, considering all this, in the VLSI, we thought of creating something similar for India. So we said that whenever you get a vial, the first sample should be sent for culture. Only once you get the culture report, then subsequent should be allocated, and these aliquots should be used for injection. Now, it was also done that a study was done, which is known as DFE, direct from the vial. What Dr. Deshpande said is very correct, that it is a preservative-free vial. We cannot insist to the company to use preservative, because these preservatives will then go intravitreally and they can be damaging to the retina. So they cannot use preservatives in something which is preservative-free. We cannot tell the company that they should come out with a single dose vial, because that is their policy, and I don't think they will listen even to the courts. We had told Roche way back in 2016 to introduce the Kessler code. DCG had told them, and they have not yet done it. So that shows that Roche can do whatever they want to do. And we can, even if we tell them, we can only request them, but it is not mandatory upon Roche to accept whatever we are saying, because it is their policy. Therefore, whether they bring out a single dose vial or not, but here we have an Avastin vial which can still be used safely if you follow the right technique as is being done in the US. That is my submission to the panelists.
I think good suggestion what you are saying. Suppose it is followed even in India, that is the perfect solution what you have said. But I think at society level, ophthalmology society level, state society or national society, and there are various companies, like suppose there is any instrument, when we suggest to that company and they come out with a special instrument that is before someone's name, they manufacture and then it is sold. So for betterment of society, benefit of society, suppose we appeal to these companies, I think not only Roche, but even other companies, and by increasing the cost of that particular single dose vial, I think that can be done. We should try on those lines. We should at least try on those lines.
Yeah, definitely.
Ajay, do we have any compounding for pharmacists in India? I don't think so.
So we don't have a compounding pharmacies like the US. And in fact, so RP Center is doing it on their own. Alvin Group is doing on their own. And way back when I was doing my fellowship in the US, we had done a small study that what happens to the Avastin when it is kept at different temperatures, that is at 8 degrees, at minus 20 degrees, at minus 40 degrees. What happens if it is kept in the glass syringe, and what happens when it is kept in the plastic syringes? So there is an interesting report which shows that if it is kept in the plastic syringes, they have documented presence of silicon droplets in the vitreous after using a drug that has been kept in a syringe which has been preserved. So therefore, keeping as aliquoted into the syringes is not the best of ideas. A better option is to keep it in glass syringes. That is why the proponents of people who are saying direct from the vial, it is kept because the Avastin remains in a glass vial.
I will further suggest that instead of vial or anything, it can be loaded syringe, glass syringe itself, which can be just taken out and pricked. Like we, as you use in many things.
Visco.
Yeah, Visco. So that is the best thing which prevents everything.
I think here it has to be constituted, isn't it? Or is it direct injectable?
Yeah, that is true. Loaded syringe with needle and everything, just prick up and use it. That is the best solution, which if the company can do it. Otherwise, why we should give the Avastin and face that the endophthalmitis will ruin us?
So this is what eccentrics came us with an eccentric PFS.
Yeah.
Eccentric PFS is preloaded eccentrics. And the concept is very simple why they came out with it. If you consider any syringe, any vial, it has got a glass topper. So this glass topper, when you prick through the, so not glass, but rubber stopper. So when you go through the rubber and when we go through the vial, a sliver of the rubber actually goes into the needle. So I had done a small study in collaboration with IIT Delhi, and we actually did scanning electron microscopy on these slivers. It is not published because, and then there was some instrument also made on this regard. I had made some instrument, but anyway, so that is the reason when you load ranibizumab, you load it by that red needle, which has got a 5 micron filter in it. It is to not only prevent anything, but also to prevent the slivers of rubber coming into the syringe. Therefore, you must always use that. And that is why the reason when you prick this vial once, you should be able to aliquot it into 15, 16 times so that, these slivers don't come into the picture.
So best is preloaded syringe.
Cost बढ़ जाती है उसकी sir.
बढ़ दे दो ना. People are able to afford. Our government can purchase and give free the people who are not affording. there is a solution, or a funding agency like social organizations are there, they can fund.
We will ask our treasurer sahab to help us with this.
Yeah, even AIS can fund.
No, basically what I think
AIS
is
can fund.
the companies, multinational companies, why they don't want to bring out the single vial doses is like probably the cost of raw material is so negligible that they cannot. Say suppose their vial is used for 5 patients now. If we ask them to bring out a vial which is used only for 1 patient, the cost will be almost similar. They would be reluctant to bring down the cost by 20 to 20% of what it is, because the raw material cost is so less. Their intellectual property right cost is so high. That's why they are reluctant to bring out single dose vials. That is for sure.
And
But
that
then
was
that
the answer
single-
given in the court by the company, that we don't want to do that and we don't recommend also. Why the doctors are using? I don't know. So they said why the doctors are using. So they are liable for that, company is not.
By in-
economics, sir. Yeah.
by increasing the cost, and suppose it is a single dose vial, and again on that vial it is written that it is for ophthalmic use. It is the
Yeah.
separate entity.
That is the
It is a
safest.
separate entity. I
No, they
think
will not write
company-
ophthalmic use because it was not, it was, though it has, a lot of studies have gone in, but so to study this, I went through the annual report of Roche, annual report of Genentech, and there was a line which we quoted in a presentation of what losses they had suffered because of Avastin use all over the world when Lucentis could have been used instead. So they are looking at all these factors, and these are financials.
R&D should work that in India, ILE should be prepared. Or similar drug
There
should
is
be
a
prepared.
possibility, Ajay, that DGCI recognizes this for the intraocular use,
Yeah.
and a specific use for ophthalmology vial is presented to the doctors. Like if bypassing the FDA, can DGCI take a decision allowing the use of Avastin, and then a vial, single-use vial for ophthalmology use be introduced in the market? Can we move in that direction?
Yeah. So the solution, to my knowledge, is to establish compounding pharmacy in all zones of country. So you have one or two for North India, 1 or 2 for East, 1 or 2 for West, 1 or 2 for Central, a few for the South. These compounding pharmacies are the state-of-art pharmacies, which is not only for Avastin, but many other drugs which can be used. So the economics have to be gone into it if it is possible. It just can't be done like that. And we looked at, so there's a person by name Dr. Jeffrey Emerson, who was the director for ASRS, and he had said he created his own clean room for compounding himself within his own clinic, and it does not cost much. So each doctor can actually create a compounding agency, compounding area in their own clinic, but then the volume of Avastin use should be significant. So therefore, if 20 or 30 doctors join in, create a compounding pharmacy, the only problem is what will be the legality of all this? That I don't know.
There will be no legality, even because you are not allowed to do the compounding. You are allowed to only give the medicines which are available, or when you are mixing a medicine, that is also should be accepted by the pharmacy, food and drugs and all the DCCI, because that is long back doctors used to come do the liquids and do so many things and mix it and give. But that time the consumer protection law was not there. So now the law is there, and now it is crores. The demands are in crores.
Yeah.
So a single Avastin patient, if you are seeing for his economy, you are drowned in the water till that you never come out of it. 1 crore, 2 crores, if it is costing 12 crores, 15 crores, how many demands are there? I have conducted the cases of 12 crores. Very easily they are demanding, because the limit is not there for a district level.
Sir, we
The
have
limit is for
Uh,
producing the bills, and bills are 1 lakh. And now they have brought to 50,000, 1 crore, and now they have brought to 50,000. So it is well, at least.
Dr.
But
Kaushik, I have got one question for Dr. Ajay. Dr.
Yeah.
Ajay, now about the developed countries like Europe, America, these drugs are available, even if those are costlier. Now we are talking about India. So what is the policy in other developing countries of the world, apart from India? Dr. Ajay, if you know.
So when we were doing this thing, we looked at some of the developing countries, we looked at the developed countries. Most of the developing countries, like supposing China is not a developing country, but when there was a Avastin problem in Calcutta, so it is believed, I should not be saying it because it's not authenticated. A lot of these drugs actually travel from China to India.
Okay.
So there are spurious drugs available. So most of the developing countries face the same problem. There are no laws. There is no law in India for the establishment of compounding pharmacies. Otherwise,
Yes.
a lot of compounding pharmacies should have been put in. We had requested DCGI that they should formulate some criteria for setting up compounding pharmacies. That has not happened. So if we as a community can go forward and do that, I think that single act of establishing compounding pharmacies can be a very major thing. But I do not know with the availability of biosimilars whether economically it is sound now. In 2016, it was a sound idea. Today, it may not be a sound idea because the cost of biosimilars is all coming down. So there will come a time when the cost of a biosimilar ranibizumab will be almost same as Avastin. Then there's no point in doing it.
No, we can suggest the government, as the government can give the subsidy to the gas, can give the subsidy to the petrol. Why not to the ILE? So give the subsidy to the ILE and make it available at lower cost so that Indian doctors also can use it and poor patient can afford.
When vacciners rates come down to the level of Avastin, then Roche will introduce single dose.
Yeah,
Exactly. That's what I meant.
that is true. That
must
government can do it.
Must write in PM's
Yeah.
मन की बात जो है ना उसमें लिखना चाहिए.
So they have a budget, they can purchase in bulk and give it to the India in lower cost. Suffer the difference, government will suffer the difference. Central government.
Dr. Kaushik, I think you have got some questions. Okay.
Yes, sir. We had some questions in the Google form. So somebody has asked, what are the legalities of bilateral injections in the same sitting in India? Bilateral intravitreal.
So should I answer?
Yeah.
Yes.
So, so we normally give bilateral injections in ROP cases. So when we have a patient where we have to give an anti-VEGF in patients of an aggressive ROP, which was earlier called as an aggressive posterior ROP, then bilateral injections are generally given. So let me tell you, in case I have to give a bilateral injections and in case I'm using ranibizumab, then ideally it's recommended that I should use 2 vials of ranibizumab, one for one eye, one for the other eye. There is enough ranibizumab in 1 vial that I can divide it to reduce the cost and give it in 2 vials. But it is recommended, though it is not said in so many terms, that, and it is practiced by some, that we should use 1 vial for each eye, but they give bilateral injection.
But what is the recommendation? In the same sitting or different sitting? Recommendation.
No, same sitting, because it is done, and for a child, you can't, it's better to give it at the same sitting. But for an adult, in case both eyes require injections, I would personally not do it, as we don't do bilateral cataract surgery.
Yeah, that's correct.
I have not done it, so I can't say. But I don't follow, and most people do not follow bilateral injections of anti-VEGFs in an adult in the same setting.
The same thing is that bilateral cataract is illegal. So doing any intervention which may cause the blindness of both eyes as a complication at a one time is illegal. So giving the injection on the same day, maybe of different vials, is also illegal. Why not to call second time and give it? Don't charge it for your visit. That's all.
Abhishek, next question.
Sir, there was another question, like what is the legal status of intravitreal anti-VEGF, intravitreal Avastin? Is it legal?
No, anti-VEGF, see, the DCGI had allowed the use of Avastin, and ever since 2016 till today, I do not think it has ever been revoked. Since it has not been revoked, legally you can use it, but you must follow all the precautions for the sterility. And now that with the biosimilars being available, that is a question each person has to answer as to which agent they want to use. We must remember that it is off-label, but in case you have taken a consent, and we, in the consent which VRSA and AS made, it was clearly mentioned that it is off-label, and patient understand the off-label use. In that case, we have to explain to them that it is off-label, but it is being used in the US. And that is what happened in the case which I showed you last, where in Dehradun, the court was given original papers published in literature which showed that Avastin is commonly being used. And the court agreed to that.
So in one word, it is off-label but legal. Should be the answer.
Anand sir, your comments?
Goes in the court, in consumer court, and demands for the blindness. If nothing, complication doesn't happen, no problem. Till you are not caught, everything is good. But once the patient goes in consumer court, you are nowhere. Even if you take the consent that you are using Avastin, which is off-label, which is used in America, so even then also court will say this is a negligence because it is off-label, and the decision is there already, which can be used.
Off-label, the decision is basically infection. The procedure of administering is held accountable.
No. So that was because there was no preservative, and second prick caused the infection. And fortunately, first 3 patients did not cause the infection, but last 5 got it because there was multiple pricks. So every prick was giving some bacteria or some Pseudomonas. And Pseudomonas was there only, which was detected.
That's what I mean, sir. That is the case. Like it is not off-label. It is not off-label.
Because you know that there is no preservative.
It is the
even a single bacteria, Pseudomonas, goes that it will proliferate.
Dr. Deshpande, sir, it means you suggest that multi-dose vial that
should not be used in that Avastin. I will say that why to use the Avastin when it is off-label and not for ophthalmic use. You are calling yourself to get troubled. May not be get troubled. No, in 100 cases, you will have no problem. But in one case, if you get the problem here and he sues you for 12 crores or 15 crores or 30 crores, then what is? Where are you?
No, but most of the VRs, they are using this, and that is for
they are using.
But recommendation is it can be used in India.
There is no recommendation. Most of the BHMS, DHMS doctors use the allopathic drugs. Nothing happens. Nobody goes against it. Everything goes well. But something, if anything happens, they are in this suit.
Sir, there are 2 things. Giving Avastin, not having complication, fine. Giving Avastin with proper care, and if some complication occurs, still there shouldn't be any problem. That's what I feel.
Proper care, there is no, that is, you are not taking the care because it is off-label. It is not recommended for the ophthalmic. So you are using the drugs which company says if you are using intramuscular injection in IV, how the company will protect you?
Dr. Ajay,
Why you
your
are
comment
using
is
that?
because
That
you
is
are
the
the
thing.
VR person and you know everything.
Why?
What is
No,
going on
no.
all over
We are
there.
a person don't think for the economy of the patient, and that is not affordable to the. Everything is affordable. If not affordable, there are many sources by which they can make it affordable. Insurance is there, funds are there, other funding agencies are there, other organizations are there who can help. National Association for the Blind can give the money. We are giving the money. So there is no problem.
So even if that multi-dose vial is there, and if you use that only for single use, still it is
and
not
nothing
advisable.
happens. It is well and good.
No. Means according to you, it should not be done. It should not be used.
It should not be done. Legally, it should not be done because
It means
Avastin company has given the witness in the court that it is not recommended for ophthalmic use. Still, the ophthalmologists are using. What we can do?
So what we
Everything
did
is
in
over.
2016, and we told government that it can be used, it must be used, like it is needed. So that
And unfortunately, a big professor, renowned professor, was to resign and was very in trouble in that.
No, sir, but the DGCI has approved its
approved. That's what I
use.
said.
So I think like we cannot like when the DGCI itself has approved its off-label use.
That did DCJ actually approved the intraocular use, or it actually lifted the ban on intraocular use?
Yeah.
These are two different things. It did not approve specifically the intraocular use of intravitreal Avastin.
Ajay, you are not commenting anything on this.
Ajay sir,
I already commented. I have said that see, Avastin, we must know it is off-label. Whether it is India, US, it is off-label.
No, it is a drug for colon cancer. They say that it is a colon cancer drug. And if you are using the cancerous drug in ophthalmology, which is not recommended, if it is useful, it is well and good. You get the use. But if something happens, we are not responsible.
So the number of patients all over the world who have received anti-VEGF,
so the government should do something that it should be labeled. That's all. So all organizations should move the government company that they should be made labeled. That's all. And everything, the problem is over. Court cannot do anything then.
So the labeling problem is, sir, that the company has to apply for labeling.
Yeah, company should apply.
The company doesn't apply.
Doesn't want to do it.
They don't
because they know it cannot be done. So they don't want to do. So yeah, they have to spend a lot of for searching a drug or something which can prevent the infection. That is, so they don't want that.
Dr. Deshpande, sir, what we say that in Medicolegal, like in court, they refer the textbook in cases of complications or medical negligence. Now, what is given in the textbook? Avastin is to be used for ophthalmic purpose.
Textbook is not recognized as a document in the court. Not recognized. All social media are not recognized as a proof or document.
No, I'm saying textbook, official textbooks. What are they saying?
Textbook, yes.
That's what I'm saying. What are they saying?
If the textbook says that Avastin can be used and there is no problem for Avastin, whether it is off-label or on, so that can be shown.
What is written in the textbooks?
I don't know, because there is nowhere it is written.
Dr. Ajay may be knowing. Dr. Ajay may be knowing.
That's what I'm saying. So all the journals, the review articles, the textbook have said that though it is off-label, FDA has permitted the use of intraocular use of Avastin. So this was, I think I projected that particular slide, which I think probably comes as the rule number 597 or 697, which is the FDA rule, which says that Avastin is being allowed to be used as an off-label drug for intravitreal injections. That is what FDA is saying.
FDA says then the court should accept the FDA's recommendation, because court should accept. That is the only thing.
But the problem is, supposing you have a drug which has been tested on adults, not tested in children, then it is off-label for children. You have a drug which has been tested for colorectal cancer and not tested for eyes, is off-label for eyes, though it may be used. So that is how the Avastin use started. It was not for eyes, but as I showed you, Phil Rosenfeld used it in a patient who had a persistent problem where PDT was not working and she had only one eye left, and it worked. So we know that it works, and the number of patients who have got Avastin is much, much more than who have got Lucentis or Eylea.
Suppose I am an ophthalmic surgeon and I also know how to do the abdominal surgery, and I have good experience of doing the abdominal surgery, and I do the abdominal surgery and somebody meets the complication. Is the court going to save me? No. Court will say you are not an abdominal surgeon, general surgeon, you are ophthalmic surgeon, stick to the ophthalmic. This is your negligence. You may be knowing or you may be having experience, everything, but it is not worth, because you are not having the degree. So this happens. If it can, you can prove it in the court, that is also in the Supreme Court, then there can be reversal of the decision. Till that it goes with.
Till that, we should follow Dr. Deshpande's advice.
Because it is a decision of the Supreme Court.
Today, what I see Dr. Deshpande as not as doctor, but as judge.
Yeah, because
basically the way forward for the company, the way forward for the company.
Yeah, that is a blame. Company is blaming the doctors, making it available, but not labeling it and making the doctors to come in trouble. And I have made the cases which are in crores. So why doctor should sacrifice his whole life?
Yeah.
If suppose Supreme Court gives the order of 10 crores, what you have earned throughout the life, you are ruined. If you cannot give the 12 crores, everything will be taken by the government and will be paid to the patient. So
डॉक्टर मराठे हम लोग बड़े इमोशनल हो जाते हैं जब पेशेंट्स आते हैं and they say
that is true because we are very good people, but our goodness should be limited to the extent to what it should be.
No, then that should be the message to all Vihar community, not to you from the very
that is true.
If it is that serious.
Yeah, I will suggest
we should
that.
Promote that. We
should
promote.
It is not
why did you fight? Why did we fight in 2016 then? We should not have fought, and we should have just forgotten about Avastin.
Yeah, the thing is that this is the recent case which I have met recently, hardly 1 or 2 years back.
Sir, Marathi sir, उस समय biosimilar नहीं थे बिल्कुल भी. And there were poor patients who were suffering. So we had no options.
Correct.
So, and eccentric, that time we did not even have eccentrics. It was available as Lucentis. And it was not possible for patients to afford. अब तो आपको ranibizumab के 5 different companies के आते हैं. Whether it is Razumab or Osiva or Razivel, or अब तो नाम भी याद लेने मुश्किल हो गए. So many companies are coming up. So we have options available now.
Yeah, options are available and drugs are available, maybe costly or maybe less costly. Ask somebody to fund. Ask the associations to fund. Ask our AIOS to fund. Help the poor people.
No. Now the question is whether AIOS or VRSI should come with that guideline, not to use Avastin from tomorrow.
Yeah, we have to be very clear. That's important. That a white paper must be brought out by AIOS or VRSI, and there, because of the legality, that ठीक है भाई Avastin को बंद कर दो, मत करो use, so that there is no confusion left in the public whether Avastin can be used or cannot be used.
Correct.
So otherwise, we'll keep having this discussion without reaching any conclusion.
That is true. You are very correct, sir. You are very correct.
Exactly, David. That's what I was saying. Like probably in consultation with VARSI, AIOS can issue a guideline to minimize the use of Avastin, use biosimilars. And when that happens, Roche will apply to DGCI for its permission to use it for ophthalmic use.
Yeah,
And
that is the
DGCI,
way. Really, Mathur sir
when
is taking.
DGCI gives
You
permission
stop
for
using it,
ophthalmic use,
they
no,
will
no,
apply for.
the next step. The next step is when DGCI gives permission for ophthalmic use, then Roche will be duty bound to bring out a single vial for
Yeah,
ophthalmology.
that is
And
Let
yeah,
me tell you, Roche
that
company
off
has
level
got a,
level will go.
no,
Yeah.
no.
yeah,
Roche,
that is the way of bringing them down.
so now
All the
rather
VR surgeons to use, nobody will purchase. Then why they will prepare it? And so naturally they will have to come down.
As it is, colorectal cancer is quite less, so there is
Oh, very less it is.
no sale for that drug
Yeah,
for that
yeah.
particular
There is
cause.
no sale for that.
It is for ophthalmologist only.
Yeah.
The sale is there.
I think Kaushik, you get on with your questions. We have to find.
Yes, sir.
Otherwise,
Yeah.
this terrible discussion will go on.
Yeah. This will not be ending.
Yeah.
So let's wind up quickly.
Actually, sir, we had other questions, but they are actually not related to this. So we'll because somebody has asked, like, what are the legalities of posterior subtenon injection? Can there be legalities?
So I think you had shared this question. So I looked up on this as to if any medical legal case has been done for posterior subtenon injection or triamcinolone. And I could not find, and Google later on told me that, I can't find an answer to you. You must refine your question. So basically, let me tell you that a posterior subtenon injection can accidentally cause a globe perforation. Can also cause injection in the subretinal space. I have myself operated upon patient who developed a retinal detachment after posterior subtenon injection, and I have removed triamcinolone from the subretinal space. So therefore, it is very important that whenever you give a posterior subtenon injection, you must know the correct technique. You must be conversant with the way you're going to follow up these patients. Because once you're given the injection, you have to follow aseptic techniques. There are few reports, one which I could document, of an orbital abscess developing after the posterior subtenon injection of triamcinolone. So therefore, infection, globe perforation, or globe surface injury are important things which you should know. Plus, of course, rise of intraocular pressure. So that should be monitored in these cases because that is very important.
So there was another question, like, is intravitreal anti-VEGF just the domain of fellow trained retina surgeons, or other ophthalmologists can do legally?
Want me to answer that?
Yes, sir.
So I don't think anything is like Deshpande said that he does abdominal surgeries also. So a person who is well trained to give an intravitreal injections need not be a retina surgeon, but it is important that you should have the abilities to diagnose when to give an intravitreal injections. You should have the ability to give the intravitreal injections. You should have the ability to follow up and manage these patients in case things go wrong. Of course, maybe not a vitrectomy, but most of these things you should be able to manage. If you can do that, then please go ahead and give intravitreal injections.
Or better to be VR surgeon.
Otherwise, if you cannot do all this and you're doing it only from a financial point of view, then I think it's better to avoid it. Or you should go ahead and do a fellowship in medical retina so that you can start.
That is the correct thing.
Yeah.
When so many VR surgeons are available, why to do it?
Why to take chance? Correct.
Why? Refer them. There is a specialist available. Around you, there are 20, 30, 50, 100. So it is very easy.
Also, another question was, sir, should the box be given after intravitreal injection if the patient asks, like, I need the box?
So the patient says, I need the box, then you have to give it. If the patient is coming from a panel, then panels like CGHS and all that, they require the box. So the box has to be returned. But if a patient is paying cash or is from a TPA, then many times they do not insist on a box. You don't have to give it. The patient only wants to get well.
Don't give it on your own.
So if the patient asks for it, you certainly should not hesitate to give the box.
And so there was another question: what are the do's and don'ts after intravitreal injection?
So do's and don'ts after giving the injections. The first important thing is that once you've injected, must remember that for the first 2 minutes, the intraocular pressure goes up. And after that, the intraocular pressure starts coming down. So therefore, after giving the injection, you should do a touch technique. So I do it with any instrument or even with the needle on the cornea to say whether the eyeball has become tensed. You can also, many people all over the world, they will ask the patient to count fingers. Can you see? So must document that patient has not become no light perception because of sudden obstruction of a central retinal artery occlusion. Some people even go ahead to the extent of doing an indirect ophthalmoscopy to look at the pulsations of the central retinal artery. So the most important fact is must check the pressure if it is high. If it is high, very rarely you have to do paracentesis. Number one. Number two, must instill topical antibiotic drops. Number three, must tell the patient that they should not splash water in the eyes for the next 48 hours. This is what I do. Most of the time, you don't have to patch them, but considering the situations in India, we tell them कि we patch them, घर जाके इसको खोल लेना, so that all the धूल मिट्टी on the way, the dust and all that is avoided. And we tell them that they should come back for a follow-up within the first 3 days. Patients who are on regular intravitreal injections, who know what the symptoms are going to be, I ask them to give me a call next morning and tell me how they're feeling. If there's anything wrong in that, in their symptoms, I ask them to come. Otherwise, I ask them to come back and show me within the first, usually on the 14th day, when we want to do an OCT and check how is the macular thickness, or for whatever indications we have used it, so that we want to monitor our patient. So this is what are the general do's and don'ts of following a patient with intravitreal injections.
Sir, in India, can we give the intravitreal injections in OPD as is done in USA?
So please understand what is done in USA. It is done in an environment that is clean. It is done in an environment that is hardly has dust. So there are numerous hospitals within the country where they have created clean rooms which are separate from the routine OPD so that the OT time is not wasted, where you will go and wash or wear gloves and follow the usual precautions, and that will be a clean area, not exactly on a chair in the OPD chamber, but in a clean room it can be done. So there are designated areas for giving intravitreal injections.
You can say that it is an interventional room and maintain it as a OT.
As good as OT, yeah.
As good as OT.
Yes, yes.
Sir, I think we completed all the questions and it was a very lively discussion, and I think AIOS and VRSI should take the call and do something to clear the legal status of this, specifically Avastin for intraocular use, because as we see, there are multiple court judgments which are against ophthalmologists for using it off label. So this is, I think VRSI and AIOS should take a call. And I would take your permission to conclude the meeting. Thanks, Ajay sir. Thanks, Anand sir, Prakash sir, Manoj sir, and our colleague, Dr. Arti, Dr. Dipanshu, and our audience. And this will be available online in YouTube also.
Thank you
Dr.
for-
Ajay sir, your concluding comments, sir.
No, my concluding comment is Aarti has not yet asked a question.
Sir, I'm not a VR I'm not a VR surgeon. I'm anterior segment surgeon. So I will just tell the take home points. Refer the patient to a VR surgeon.
I
Correct.
enjoyed. I
Correct,
think
sir.
It was
Yeah,
a
no,
very
it's doing
good
a great
presentation by
job.
Ajay, really informative, and like we really learned a lot from today's talk.
Yeah, very nice topic was there.
It
Very
was
nice.
fantastic discussion today and on the topic. It was definitely benefiting to all the youngsters and VIAS and YOSI members in the country. Definitely.
Thank you.
I-
very
I-
Really
much.
hands up to
I didn't
Arti
think
for
that this-
selecting this topic.
I didn't
Thank
think
you
that
so
this
much.
topic will be that hot for discussion today.
Yeah. Thank
We have
you.
made it hot, sir.
Yeah. Thank you. Thank you so
Thank
much.
Thank you so much, sir.
Good
Thank you,
night.
sir.
Good
And
night, all of you. Good night. all
Good
of you.
night to all.